Simple questions you are asking. If you answer, you get 6, 7, 8. If you answer a bit better, I don't take the marks in my pocket. 9 I will give. In the viva table. And simultaneously, I'm telling you, be very focused. Last year, more than 50%. Anyway, supplementary, I've seen many boys, girls, I did not expect. There might be some technical or there some questions they could not answer, whatever it is. But please take care of yourself. Now, describe the demonstrate major viscera of the abdomen under the following heads: anatomical position, external and internal features, important peritoneal and other relations, blood supply, nerve supply, lymphatic drainage, and applied aspects. Any organ, any structure has to be supplied by a blood vessel, drained by your vein and lymphatics, and it has to have a nerve supply. So your 3 marks is there. Hold it in anatomical position or leke baith gaya. Liver leke baith gaya. Stomach leke baith gaya. Someone is holding like this, someone is like this, doing jadoo. So, a stomach is an organ that food goes into it via the esophagus. It goes into the cardiac end of the stomach, cardiac. Heart is on this side, except for dextrocardia. But it has to go on the left side. When a patient, a person is with dextrocardia, the stomach is in its own position. But when the rotation in the embryology or whatever it is going on, in organogenesis, the cecum can be here, subhepatic, with the appendix. The cecum, the malrotated, or in the left portion. Appendix on the left side. It can happen. Very rare, very rare. Now, you have to pick up and say, don't allow the examiner. I'm saying this term I'm using. Don't allow the examiner hold it in anatomical position, hold it this. You'll be wasting time. You have to go through maximum 10 minutes. We are rushing. You are rushing. So you have to just see the basic features. Okay, ठीक है. You take this. Now the uterus. I'm just doing a bit of postmortem of yesterday's exam. Holding the uterus, the ovaries in the posterior aspect, the fallopian tube and the round ligament in the anterior. So round ligament, the ovary is not attached with the round ligament. When I am asking for this is what? That's in broad ligament. So and see cervix. I'm asking, what is this? Blank. Then cervix has an external os and internal os. There are specimen, I have made a cut uterus and you can open like this. Then you can see the external os and the internal os and also a slit. That is the uterine cavity. I'm pointing, what is this? No answer. So forget everything. You become focused. Identify your stomach in the practical class. ওই একজন দেখলো, একজন দেখলো, আমি হাত দেব না। See, if you are on duty in internship in gynae and obstetrics department, there is a patient in the table on normal delivery. She is at the head is coming out. You have to make a episiotomy stitch. Open up, make an incision, episiotomy, and the head suddenly comes out. You have no time to wear gloves. Handle with your hands. The potty and everything will be there. But you can wash your hands, you can wash your hands, you can clean your hands. You saw the picture on the left side of the entry of the Department of Anatomy. Shushruth, he is performing plastic surgery without gloves. So I am trying to tell you, if you have gloves, it's okay. But আমি পকেটে গ্লাভস থাকলো না, আমি হাত দেবো না, নো নো নো, ডাক্তারি এভাবে হবে না। ওকে, একই কথা বলে যায়, কারণ 5টা ব্যাচ চলে, one batch will go off. The same 5 years I have been observing these things. I've shared it with you. Now, stomach. Stomach is a muscular bag that intervenes between the esophagus and the duodenum. It acts as a reservoir of food and converts into chyme with the help of acidic juice. Greek and Latin, I'm not saying anything. Functions of the stomach. The functions of the stomach are as follows: serves as a reservoir of food, secretes gastric juice containing hydrochloric acid and pepsinogen, mixes the food with gastric juice, softens the food. Hydrochloric acid of the gastric juice kills microorganisms of the food. Pepsinogen helps in digestion of protein. Mucus secretion protects the lining of the epithelium of the stomach. Castrol's intrinsic factor of gastric juice binds with the vitamin B12 and helps in its absorption in small intestine. Stomach is a site for absorption of glucose, sodium, alcohol, and so on. Now, if you are vomiting or you are having diarrhea, dysentery, acute dysentery, then what we do? Your home remedy. Home remedy means you take salt, pinch of salt, pinch of your sugar, and then no limbu, or if you have limbu, you have to taste. So you just give, your mom gives you a sarbat. It can be good also. But if sodium is given in more quantity, you take 2-3 glasses in 1 hour interval, then you might start vomiting again. So, in the ORS, whatever you are having, a patient you would tell 2 teaspoons in 1 glass. 1 glass you say like this. You give 2 teaspoons, but sometimes they'll take water little. So they'll give, you tell them 1.5 teaspoons. This is the absorption of the sodium that creates the centers in the brain, and that this thing propels the stomach and hyperperistalsis, then the vomit. Okay. Even when you were a child, you make khichdi. Sometimes, due to my youngest granddaughter, she's having some problem. But that medically, anyway, the reflexes of the gastrointestinal system in esophagus to stomach. If she takes a big grain or something, it's very hard. The children move about, they take something. Then she starts vomiting. Oh, something is there wrong. So my daughter makes a paste and then, now slowly, she can take muri, she can take bit half your rice or something like that. So you are asked to chew properly and take food. Especially when you go to restaurants, sometimes in a hurry, you starter is there, kebab and everything, paneer or something like that. Some cucumber, vegetables, the lettuce leaf is there. Even you're drinking alcohol, a beer, it can be a whiskey. Now what happens in a hurry, in a maja, in a competition? You're gulping. Please don't do it. Because if a big thing goes stuck in the pyloric end, then it gets stuck. It's a small canal. Now, the esophageal end, it is wide, an opening. It goes to the stomach and then churns up, storing what to deliver, what to go. In that respect, slowly it goes to the pyloric end. In this respect, I tell you, this is the stomach. You are taking a food like this. Like you see, it's like a channel. You're going in 180 speed. Suddenly there's a barricade. You have to. That's why the nature is such that it adjusts according to your control of the sympathetic and parasympathetic. Now, so happens due to pyloric stenosis. It is many causes can be there. If an ulcer, then that heals up, passage becomes very small. Even the finger, the little finger, the scope, duodenoscope, upper GI endoscopy, if you put in, it doesn't negotiate. This is one thing. But if the patient says, if any patient is thin, skinny, due to repeated vomiting, then it is due to the stricture that is caused, the fibrosis of the pyloric end. So you ask the patient, or when you open up, hey, pet khula dao. Then he just puts his shirt up. No, you have to see up to this. Tule debe, kurti puro tule dile, inner vertebra tule dile, up to this. Then you can see the waves. That is your first diagnosis. And one thing, that there is some problem with the pyloric end. Or it can be a growth in the lesser curvature or greater curvature. That takes the space. So you can see the waves. And if you lie the patient, in this end you just do like this. You will see, you hear a sound, and also the waves get stimulated, the stomach musculature gets stimulated, and it goes and propels. And you ask in such a question that you are seeing on Monday, then you ask the patient, "Tumi kalke, but yes, Sunday, did you take any shak, any salad?" That comes out with the vomiters on Monday or Tuesday. In our days, we used to diagnose. We just didn't have the endoscope. So you will definitely diagnose with an GI endoscopy or barium meal, but you have to know the pathophysiology and also know the anatomy. Now, it is this location. See, location, stomach occupies the left hypochondrium, umbilicus and epigastric region. Most of the stomach lies under cover of the left costal margin and lower ribs. Shape, stomach is usually J-shaped, called asthenic or normal type. Some interesting facts: in tall persons, stomach is hyposthenic. It has vertically placed longer limb of J. In strong, active people, the stomach is hypersthenic, steer-on shape that has obliquely placed. Limb of J is in cadaver. The stomach is sickle-shaped due to loss of muscle tone. The shape of the stomach also depends upon the volume content of the stomach, position of the body, and phases of restoration. The shape of the stomach can be studied on barium meal and radiography. Now, the size of capacity stomach is very distensible organ. The capacity of stomach varies with the age as follows. Just know the numbers. Puberty 1000 in adults, 1005 ml. Grace and length 25 centimeters. This is the cardiac end. This is the greater curvature. This is the lesser curvature. This is the duodenum, lesser curvature, and pyloric end. The stomach has the following features: two orifices, cardiac and pyloric, two surfaces, anterior and posterior, and or superior and inferior in empty stomach. Now you see some interesting facts. Previous concept: the stomach has anterior and posterior surfaces. Current concept: when the stomach is distended, it has anterior posterior surfaces. When the stomach is empty and contracted, the anterior surface faces superiorly and the posterior surface faces inferiorly. Now, see the esophagus, this is fundus, this is the cardiac end, the lesser curvature, this is the angular notch, and you see the pyloric canal, pyloric antrum, pyloric end, this is the pyloric end. Now, this is the same repetition. Anatomical position. See, hold the stomach in such a way that, now you have this specimen in our anatomy lab. Lab means your dissection hall. You, after studying theory, go and see it. Pyloric end, thick, like I'm saying this is the fist. It is like this. Circular muscles like this. The opening is this. Now you hold that first, because the esophageal end is not connected. Esophageal is not in the specimen. So you just, I want to say that specimen might not be there. We can have a new specimen. You please see the pyloric end. You hold the pylorus. You see the thickness. You see the opening like this. Now, your greater curvature, lesser curvature. Now, if you turn it, the pyloric end comes this side. So there shouldn't be any mistake. So you hold the pyloric end like this. Yeah. The cardiac end like this. The stomach is flat anterior-posterior, concave lesser faces to the right and convex greater curvature faces to the left and inferiorly. Thick pyloric end is directed downwards and to the right. The cardiac or upper end of the stomach is higher level and to left than pyloric end. This is your pylorus. This is your esophagus. Here. If you do it, you hold it like this. So there cannot be a mistake. Now, cardiac orifice, it is also called gastroesophageal junction or cardiac end of the stomach. At cardiac orifice, the esophagus opens into the stomach. Location is situated behind the left seventh costal cartilage, 5.5 centimeters from its junction with the sternum at the level of T11. It is about 40 centimeters from the incisor teeth. This part is important. Incisor teeth up to the cardiac orifice. So the thing is in the your deviated seventh costal cartilage. It can be on the surface marking. Okay, cardiac orifice, surface marking. Then you have to know these features, the seventh costal cartilage, 5.5 centimeters from its junction, with the sternum at the level of T11 vertebra. It is about 40 centimeters from the incisor teeth of the adults. Now, some interesting facts. Z-line is a line of demarcation at the gastroesophageal junction. It separates pale-colored esophageal mucosa lined by stratified squamous epithelium. The pink-colored gastric mucosa lined by tall columnar epithelium. Z-line is circumferential zigzag line, pad of fat that lies externally and the gastroesophageal junction helps in surgical identification of cardiac end of stomach. The sphincter at the cardiac end is physiological and cannot be demonstrated anatomically. So if there is any, it's physiological. Like now pyloric orifice. The pyloric end, the stomach opens into the duodenum. Location, it lies about 1 to 2 centimeters to the right of the midline at the level of the lower border of L1 vertebra. In empty stomach, it is supine in position. This lumbar 1 vertebra, this 1 to 2 centimeters on the right of the midline. Some interesting facts. Identification of pyloric orifice end. The pyloric orifice is thicker, feels nodule-like due to presence of muscular pyloric sphincter. This orifice is demarcated by a circular groove or pyloric constriction created by pyloric sphincter. The pyloric orifice is identified pre-pyloric vein of Mayo, which lies in the front of the pyloric constriction. Mayo is the US surgeon, founder of Mayo Clinic, is very famous. And the pre-pyloric vein of Mayo drains into the right gastric vein, tributary of the portal vein. Two curvatures. Stomach has two curvatures, lesser and greater. It is concave, forms the right medial border. It is J-shaped. Angular insula, angular notch is the most dependent part of the lesser curvature. Attachment, the lesser curvature gives attachment to two layers of lesser omentum, which contains the anastomosis, the right and left gastric vessel along the lesser curvature. Now, greater curvature, 2 to 3 times longer than lesser curvature. It is convex in the form left lateral border of the stomach. Cardiac notch separates the esophagus from the greater curvature. Attachment, the greater curvature of the provides attachment to the following structures. At cardiac end, gastrophrenic ligament. Opposite the fundus, gastrosplenic ligament. Rest of the greater curvature, anterior to layers of greater omentum, which contains the anastomosis, right and left gastroesophageal vessel along the curvature. Now, the stomach is highly vascular. When the abdomen is open, when you see, you will be assisting in surgery, you can see the vessels. It is very much vascular, and the thing is that this can be felt in an open abdomen during surgery. Now, two surfaces. Stomach has two surfaces, anterior, that is known also superior and posterior. Anterior surface, the anterior surface is distended, stomach faces superiorly when it becomes empty. This surface lies anteriorly between lesser and greater curvature. It is covered by peritoneum and related to the greater sac. Posterior, inferior surface. The posterior surface of distended stomach faces inferiorly when it becomes empty. This surface lies posteriorly between lesser and greater curvature. It is covered by peritoneum and related to lesser sac. These all abdominal organs are covered by peritoneum. It is, but the organs are all extraperitoneal. When Dr. Roy will be teaching you peritoneum, he will tell you that. But you know that all the organs are the abdominal cavity that is open. The beautiful dead bodies are there. Even you can do a bit of revision of the heart and the thorax. Beautiful, beautiful. You go today, Avinash, dead body গুলো রাখা আছে বলে দিয়েছিস সব তার next week okay, it will be there. These bodies will be for your exams also. So you get an opportunity, please see them. Now, actually, what is your studying? You are attending class, you are giving your attendance, but productivity. There is some link is missing. Or you are thinking, oh, to manage hoye jabe, ami to bujhe nebo. Don't leave it. Half an hour you get in that lab, you please see it. Gurte gurte dekhe nile. Whoever is demonstrating to you, by that time you see the other three bodies are there. You quick see the heart and the lung and the thoracic cavity, the sternum, the whole of the thing in the cage is turned up, turned like this, in supine position. The heart is there. If you had some big jars like this, I think I would put that, cut it and put it there. Till now, from the in 2020, two dead bodies came. From that day, I have seen that beautiful bodies. You are lucky. You are lucky enough. Even in foreign countries, USA, they don't get an opportunity to see these dead bodies. Now, previous concept, stomach has two parts: cardiac part that includes the fundus and the body, pyloric part that includes pyloric antrum, pyloric canal. The fundus of the stomach is filled with air even when stomach is empty. Gas in the fundus is clearly visible in radiographic examination under the left dome of the diaphragm. Now, this is one thing you ask for a radiograph on just plain radiograph of the whole abdomen. So you will see gas shadows of the colon. If there is an obstruction, intestinal obstruction, then you will see the gas shadows. And in the stomach, it will be like this. Traverse area, it is the area overlying the fundus of the stomach, which is tympanic on percussion, Ludwig Prove, German physician. It is bounded by superior lower border of left lung, inferiorly left costal margin, in the left spleen, on the right lower border of the left lobe of liver. This Proves space shows dull note on percussion in case of pleural effusion and splenomegaly. Now actually when I was a child, I used to see my grandfather and father that they are doing this. I used to think that just what they are doing. The sound, okay. So even the cardiac area of cardiac dullness is right in your thorax. Similarly, in the stomach, it is the dull, dull. আর আমার মজা লাগতো যে এটা কি করছে, I used to see, look into it. So I used to ask my father that actually grandfather in the village used to stay. So I had little opportunity, but every summer and winter vacation I used to go there. But my father, I was a kid, I used to move around the nursing home. When I was in class 4 or class 3, that I'm not a kid. I'm a kid, I think, I don't know. So I used to feel, it was like, it was a bit interesting to me that what is doing this. And when I came to medical science, I started to realize after reading anatomy that this has some significance. Okay. Now, see, now, Avinash, ওখানে abdomen open করা আছে, তো এই ওমেন্টাম এগুলো সব রাখা আছে পুরো বডিতে আছে। তো you will see there are 3 bodies, 3টে আছে না 4টে বডি আছে? Okay. You will see, please, when the dead body is out next week, even if you have, it's not, of course, abdomen and pelvis is there. So you please take your time, observe all thorax, the beautiful, there's the dome of the diaphragmatic surface, the liver is there, the thing, the total thoracic is anteriorly cut off and put down. And you can see the heart. Beautiful, beautiful. Don't tamper, don't pull, but you see for yourself. You just put your fingers, your gentle fingers, and see. If there is a cleft, you see the apex. And if you put your finger in the diaphragm, you can see, feel the liver. Just below the diaphragm, you can feel the liver from the thoracic cavity. একবার দেখে নাও, মনে থাকবে. Go and read, draw enough, as you see it, you come out and draw a figure. Just rough. You just see, like I've been drawing. I always draw in my prescription because see, this is the stomach. Hey, stomach nahi. This is the diaphragm. Now, the gallbladder, stomach, the stomach will come in this position. But when I'm focused, there is some condition of the your hepatobiliary system with the patient with the jaundice. Then what are the possibilities are there? Now, if he is coming for the first time to your clinic, you please see, and if their liver is enlarged or not, then you make a point like this, 2 centimeters enlarged. Now, when the respiration is going on, you palpate, you press. When I teach gallbladder, I'll tell you that there's Murphy's sign. Then there's pain. You ask to inhale. Put your finger like this, you're palpating, and suddenly you press. You catch your breath. ব্যথা হচ্ছে? হ্যাঁ, এখানে ব্যথাটা বেশি হচ্ছে। Murphy's sign positive. Then send for a USG. You see the USG, you see if there is any mass, if there is any lymph nodes or anything, or some growth of the, you just draw sketches like this, and simple, that's the rule. Now, stomach is lined by peritoneum, surface is the bare area of the stomach. The bare area of the stomach. It is a small area that is devoid of peritoneum and contains some direct contact with the left crust of the diaphragm. It is located near the cardiac end of the posterior surface. Folds of peritoneum extending from stomach. Lesser omentum extends from the lesser curvature. This is. Now, greater omentum extends downward from the greater curvature. This is the greater. Now, greater gastrosplenic ligaments extend from the upper part of the greater curvature to the spleen. The spleen is located here. Yeah. Now, gastrosplenic ligaments extend from the fundus of the stomach to the diaphragm. Gastro splenic, gastro to spleen, gastro to the diaphragm. The gastrosplenic, phrenic. Now, thus, the greater curvature of the stomach gives attachment to the gastrophrenic ligaments, gastrosplenic ligaments, and greater omentum from above downwards. This type of drawing. Okay, see, hepatogastric ligament, hepatoduodenal ligament, lesser omentum. This is the lesser omentum. Now, this is the duodenum, the stomach, diaphragm is here, and you will see the spleen here, gastrosplenic ligament, this greater omentum. Peritoneal relations, you have seen the lesser omentum, gastrosplenic. Now, anterior surface, left lobe of liver, quadrate lobe, diaphragm and anterior abdominal wall. Now, posterior surface, stomach bed. This is a short note. And also, if you are answering for honors, the examiner might ask you in viva, what is the stomach bed? What are the organs in the stomach bed? Now, you just spleen, diaphragm, left suprarenal gland, left kidney, splenic artery, pancreas, left colic flexure, and transverse mesocolon. When you go see the dead body, you just see these. It will be in the stomach. You just lift up. Then it is lying on these organs. কি হতে পারে? এটা আছে. Now stomach এদিকে pyloric end. Then what are the structures? The pancreas. You can have left your spleen and your left kidney, left splenic. This is normal. Male, the kidneys in their position and testes here. But previously, previously the testes were in this way, when organogenesis, embryogenesis is occurring. The testes are in the level of the kidney. These are gonads. Now, incomplete descent of testes. Maharaja is given a red carpet and the testes descend up to the scrotal sac. Any place it can be arrested. Now I was telling about the plate I've seen on the right side, there's a kidney here. This is off, like this. No, this is not, it is having a testis here. Now, the testis come. It cannot go to the, it can be high up, it can be in the portion in the mid-ureter level, then it can go into the inguinal deep ring, then external ring, then to the scrotum. Through the inguinal canal, it can arrest. That is incomplete descent of testes or undescended testes for your short note or question. Now, I'm talking about the thing. Now, it can even, that can happen here. Now, if that's why when you are seeing the dead body, you feel stomach puts stomach put. It's not that. Stomach bed. For ages, this a question comes. Or in viva they'll ask you. The stomach, वो तो महाराजा है ना, वो तो सोते हैं ऐसे, with food and everything. Now, of the anterior surface, stomach is related anterior in the following: left lobe and quadrant lobe. Liver are related to the right part of this. Diaphragm separates the upper and left part of the stomach from the pleura, base of the left lung. Okay. Now, pericardium and heart and left and ninth costal cartilage here. The heart, the apex beat of the heart. So, yesterday's viva exam, I asked them, where you get the Dil Ka Dharkan? Kajal and Shah Rukh Khan. Okay, blank, point blank. You auscultate your friend's heart and you will be seeing where's the apex beat. You become a model, your roommates. She becomes a model, roommate. And read anatomy. This is Professor Higgins. You can just for a curiosity, I told you in the initial stages, I met him. You just see his website and you see how all living animals and all human beings, you see the dissection and plasticinization. Now, you can see these positions are important. The sixth cartilage, ninth cartilage, all this position, okay? Now, yeah, see again, it's a repetition. That is, write a short note on stomach bed. See? Amar বক্তব্য হচ্ছে, you are seeing it over there. You have your atlas. Bag নামাচ্ছ না। কাঁধে নিয়ে মাইক্রোস্কোপ দেখছো। You have, when are your exam? 4 months. So you please recover from these obeisance and these habits. You try for 1 month in this abdomen and pelvis. And if I am wrong, I will just do this up and down. You have to integrate, you have to put your heart and soul into it. शुद्ध रटने वाला नहीं है, 1 2 3 1 2 3. Just to say, when I took your bones in the lower limb, you have some landmarks. In the upper limb, I asked for an anatomical position. Anatomical position बोलो, ये बोलो, किधर रहता है, क्या करता है, ये नहीं पूछते. ये बोलना है आपको. And I'm telling you, you are lucky. I have not come across such dead bodies. You have your tab, you have your learning material which you are comfortable with. But don't go for AI. What are the stomach bed? ये क्या पूछना है? तुम्हारा किताब ही काफी है. Okay, we'll meet in the lab and see. Choker में तो बाहर छोड़. Vasculatures. Even there's you are seeing, excuse me, you are seeing prosected dead bodies that has been dissected by some person. Now, you don't dissect. So you have your atlas or tab, and also you see the orientation and its place where it is staying. Like you go yesterday, when I asked the uterus to hold the uterus, like this, they're catching, they're covering. You have to take it like this. You have to take the stomach like this. You have to hold the liver like this. It is an art, it's an art of learning anatomy. Okay, you carry on, don't fear. 60, aim at 60. Just your previous batch, I was getting down from my car. He came at the end, 3 months left for exam. Oh, sir, sab bhule jache. So I told him the method. That's what I'm telling you. তুমি যখন লিখবে আর ছবি আঁকবে থেকে যাবে তার সঙ্গে তুমি ট্যাব দেখো ইয়ে দেখো যা দেখবে দেখো ছবির জন্য দেখতে পারো কিন্তু তোমার বইগুলো এত ভালো কারণ ইন্দ্রবীর সিং when he was live I was a student, postgraduate student. I used to go to conferences. Then Bisram Singh, he was in AIMS. Then he's I think just junior to me, no, same age. And they have written books. So your evolution of medical writing in India, we are the largest in the world, and these books are being exported. So you have that information there. তোমার এই ফোন ব্লকেজটা রেখো না দেখে নিলাম ঠিক আছে তুমি একটা ক্রাউড আছে you are having more than 150 students. Next year it will be 250 students. Now the thing is that but whatever information you are getting from the lectures or the demonstration you hear, and then half an hour or 1 hour whatever demonstration is there, you go back and see. If you are having biochemistry, do it in the evening. Daily কাজ শেষ করো এই যে biochemistry স্যার এরা সব they had some information to take from him. So beautifully explained in one chart. That you might not get it in your book. বইয়ে আছে ওটা? না। তাহলে কিছু কিছু ইনফরমেশন আমি তোমাদের বলছিলাম তো সিলিয়াক আর্টারি কোথা দিয়ে যাচ্ছে, why it's going through this, passing through this. I mean, that's not your thing. You identify, you write notes, add a figure, you'll get marks.